Okay, so what will be the discharge criteria for a 40-year male which underwent day surgery, shoulder arthroscopy under interscalene block? Okay, there was no comorbidity. So what will be discharge criteria? What is usual discharge criteria?
Usual discharge criteria for a day surgery is the PADS score.
Okay. What is that?
Remember its abbreviation, what it stands for, but there are certain things to be seen in it.
Discharge scoring.
Yes, sir.
System.
Sir, we see the vital signs, the blood pressure of the patient, blood pressure and pulse should be within the 20% of the preoperative value.
Okay, vitals. What else?
And sir, activity of the patient. He should have adequate muscle power. In our case, when the interscalene block has been implemented, then the power of his arm and his respiratory effort should be seen.
Okay. Does the patient need to be mobilizing the hand, or the patient can be discharged with the sling?
Yes, sir, of course. Yes, sir. Patient can go with the sling, but isn't it so that we have to see that the muscle power has regained and there's no neurological deficit left?
No. For what is the discharge criteria after a surgery, day surgery? If you can recall this thing, then the second stage will be easy for you.
Sir.
Discharge.
Your screen is not visible.
Just a second. You know, I give you one example that if you want to tell any scoring system or anything, you don't need to tell directly. You can say that what is the discharge criteria after a day surgery?
Absence of nausea and vomiting.
We had
inadequate.
And the scenario is that we had a 40 years old male who underwent day surgery for shoulder arthroscopy under interscalene block with no comorbidity. So when would you like to discharge the patient?
When there is adequate and relief of pain, and the patient is no episode of nausea and vomiting, and we will do X-ray and X-ray for the evaluation of pneumothorax. Can we do?
Okay. What will be the sign symptoms on which you like to do X-ray?
Shortness of breath.
And what about vitals? What about pain score?
Hypotension, tachycardia,
blood pressure, heart rate, pain.
Pain score, we can there is three real analog score and numerical score. Numerical pain score we can analyze from this how much pain the patient is having.
Okay. What else?
Bleeding, sir. Surgical bleeding.
So bleeding is the thing which you are missing. And You see, don't need to use the names straight away. Okay. So you can say that there will this patient may be evaluated by the combined surgeon and anesthetist, and then their vitals should be within 20%, as we told. There should be no problem with blood pressure, heart rate, saturation, okay, temperature, the vitals, and then pain, bleeding, okay. Interscalene block, if it was done under ultrasound, and apparently there was no, because the time at which the block was given and now how many hours have been elapsed. So usually if there is no clinical sign symptoms, no need to do x-ray, because if for example during ultrasound, during conduct of interscalene block, there was pneumothorax, it will be evident with that within that hour. Okay, there will be some respiratory symptoms. If you are talking about, you should be saying that if there was no comorbidity, okay, so there will be no problem. So actually it was a very simple question. They can this may not be the direct question. This may be a part of that whenever they are asking you about any shoulder surgery or any surgery, they can ask you about the post-operative discharge criteria. So you don't need to straight away, Zishan, if you don't know the even abbreviation of pads, if you will use this word, what will happen? Just tell me.
Yes.
No need for you to start with that I know this is the pads and you even don't know the abbreviation. So what will be the impression given? Okay. So if you are telling the pads scoring system, then even you don't know the name, for example, they will not fail you. Okay.
Right.
So this is very basic question. You should be knowing about discharge criteria. That
about the previous thing that we were discussing, that if the interscalene block was used for anesthesia purposes, and for discharging the patient, we don't have to wait for the neurological function to
just tell me one
in
thing.
Any kind of block.
Just a second. Did you try to see whether that block
yes, sir,
was?
I saw.
You did not even ask whether the patient was under GA or under pure interscalene block. Even if they have said that it was done under interscalene block, you may ask whether it was for anesthesia or analgesia. Okay. Right. So you have to be very clear about things. Maybe there was some sports injury and they did it under GA with interscalene block. They have given you open thing. So you can say that better the data which they tell, usually you have to elaborate. Okay. So you have to say that it was GA with interscalene block or only with interscalene block, because the question again, next question may be, what are the nerves which need to be blocked for shoulder arthroscopy? Okay. So in addition to the interscalene block, you need to block supra clavicular block and what is that one?
Musculocutaneous nerve is really.
There is dorsal scapular nerve, if I'm not wrong, because these things. So you just confirm it. Okay. So you had a next. Dr. Zubair, you want to answer? Who wants to answer? Dr. Rizvi?
Ji, sir. Bismillah.
Okay. So the question to you is that you had a 50 years female for carpal tunnel release. She's diabetic, controlled, hypertensive, controlled on oral medications. Okay. So what the first question is, what are the choice of anesthesia? So what will you answer?
Sir, if I'm not wrong, median and ulnar nerves can be like we can
Straight away your
these.
answer should be, what are different choices of anesthesia, and talk in English. What is the choice? GA?
And we will see the risk versus benefit. Like we can go for GA, but GA will be a bit more invasive for it, I
Did
guess.
they ask you as an examiner, if I ask you what are different choices of anesthesia, what should you answer?
General anesthesia and
yes,
regional
and
anesthesia.
regional anesthesia. Okay. So among regional anesthesia, what are options?
Median and ulnar nerve blocks. Maybe.
Median, ulnar, only medial ulnar nerve block, or you need radial as well?
Yes, sir, radial as well.
Is radial is needed?
No. Sir, carpal tunnel, median and ulnar will be enough, I guess, because
yes.
radial supplies the posterior part.
Yes, so radial is not needed. Okay.
Yes, sir.
So how medial ulnar block. Then what else? What about bias block?
Yes, we can go for bias block too. Yes, exactly.
And among the brachial plexus block, which is the best choice?
Auxiliary blocks.
Sorry?
Auxiliary blocks.
Auxiliary. Okay. Supraclavicular. Infraclavicular. This one is not a good choice. Interscalene. Why?
Interscalene.
Why? Yes,
because sir, it spares the ulnar nerve, na? Ulnar
yes.
spare.
Ulnar
nerve is spared.
Sparing. Okay.
Yes,
so if they are asking you about choice of anesthesia, you have to tell that we can give either GA or regional anesthesia. Okay.
Yes, sir. Yes,
so and you will say, I will discuss with the surgeon about their plan, and usually there is no need for tourniquet surgery. Okay, but in special scenario, you still have to ask whether they want to use tourniquet or no. Okay, this is the basic principle, that what is their plan, how much is the duration, because your plan will be according to, like for example, if they want to do it in 15 minutes, then bias blocks is not a good choice. Even
good choice, yes.
These days, be a bias block with the era of ultrasound, bias block is never a good choice. If you have to be knowing about bias block. What are the things which you should be knowing about bias block? Which medication is choice?
Lignocaine.
Lidocaine or prilocaine?
Yes, sir, prilocaine.
Okay. So what is the problem associated with prilocaine? In addition to last, of course.
Methemoglobinemia. It causes methemoglobinemia.
Okay. So you have to be very mentally prepared. What is methemoglobinemia?
Hemoglobinemia. There's an end product with the breakdown of.
It is an abnormal hemoglobin. If you don't know, even then you can make a smart answer. It is an abnormal hemoglobin in which there is decreased oxygen carrying capacity. Or impaired oxygen carrying capacity. Okay. Actually, there is a reduction or oxidation. I always forget. So either there is a reduction or oxidation of it. I apology for it. Either it is Fe plus 3 or Fe plus 2. It is changed. Okay. You can just confirm it. So there is a reduced oxygen and the saturation which is coming is 85%. Okay. Another option, question they can ask, methylene blue is the treatment. Okay.
Yes, sir.
Okay. So prilocaine, what is the, how much dose is being given?
No idea, sir.
So you should be knowing about bias block. Okay.
0.5% prilocaine is used. 0.5%.
5% prilocaine. How much?
And even for lidocaine, it's the same 0.5%. The quantity, if it's a small arm, we can go for 30 ml, and if a large person with a large arm, then 40 ml.
And usually there is pneumatic tourniquet, dual pneumatic tourniquet. Okay. Tourniquet. Okay. And then they can ask you how to perform it. How will you perform it?
For the buyers will inflate the tourniquet and inject the, I guess, local anesthetic in.
No, there are special. First, we should have two IV cannulas, one in the affected the arm where the bias block is to be placed, and one in the other arm that would.
Recently, we did regional anesthesia. I explained the basic things. You never have to forget that you have to be ready for general anesthesia, the slim rag formula. If you can just have a look on the YouTube discussions, you will find it in the regional anesthesia. This slim rag. Okay. So you have to sell that. I have to prepare for general anesthesia and on resuscitative medication. I have to explain the patient. Okay, we need to give some analysis. Then we will take consent, explain, and this and that. And then you can always say that I have to calculate the allowable safe toxic dose. And then you will take 2 IV cannulas and you will apply the tourniquet, and then you will inflate both the tourniquets. Okay.
Yes.
Or you will inflate the proximal first. Okay. You will inflate the proximal first, and then you will give the medication. And then what will happen?
Then when the pain develops, if the patient develops pain in the proximal tourniquet, then the distal can be inflated and the proximal can be released.
Yes. Okay. So that the medication is there. And then if the surgery is finished in 15 minutes, you will keep it up to 30 to 60 minutes. Okay. And then you will gradually deflate it, and you will be ready for local anesthesia toxicity. Okay. Then the next question related to that will be, they can ask you what is last, how to manage it.
Last is local anesthesia systemic toxicity.
Okay.
In local anesthesia systemic toxicity, we usually have a neurological and cardiovascular compromise. There can be very subtle signs like perioral tingling in the fingers, dizziness, drowsiness, and patient can have full-blown coma and respiratory depression also. And in the CVS, there can be bradycardia, hypotension, cardiac arrest, or arrhythmias.
Okay, there you can say that there will be resistant cardiac arrest, especially if bupivacaine is used. Okay. Neurological, there is a terminology. There is like cardiac. Sorry, this is not working nicely. Cardiac over neurological symptoms. Okay. So with the the lidocaine, neurological symptom occurs first, then cardiac. Okay. And in bupivacaine, the cardiac symptom may occur before neurological symptom. Okay. Or can occur together. This is the theory. And what is the treatment?
So treatment starts with the control of airway, breathing, and circulation. We have to administer 100% oxygen if the patient is
You are
has
feeling you are missing the call for help always. There is a number for it. Okay. Not forget. Airway, breathing, circulation, call for help. Then
help. Then we have to
you have to follow
means
ACLS protocol.
follow the ACLS protocol if there is a full-blown cardiac arrest.
And there
We'll
is
continue with CPR, and then
traditional
we
is
have to
intralipid.
administer intralipid 20%.
How much is the dose?
So 1.5 ml per kg is given initially in
And
1
what is
minute,
the
and
maximum
then
dose? What is the maximum dose?
so it's 10 mg per kg.
15 ml per kg, I guess.
It is 12 ml. Remember, Zishan, these are only one of the few doses which you need to remember. Okay, you should be knowing about the dose of dantrolene. You should be knowing about dose of intralipid at least.
Yes, sir.
So I don't think so. You should not be memorizing it up till now. Okay, you will be saying that I will be giving 1 ml bolus and is infusion. Okay.
Then infusion of 15 ml per kg per hour, sir.
Yes. 15 ml per kg per hour. Okay.
Yes, sir.
And
It is
then you can
continued
repeat a bolus and double the.
after if after 5 minutes there is no recovery, then we will repeat the bolus and we can double the infusion dose.
And when the total dose is reaching 12 ml per kg, you will stop. Okay. You don't need to say 5 minutes. If you are not able to see any response, then you repeat it. It is better if they ask the time, then you say it. For example, in their key, if they have written 3 minutes, then so it is better to be smart. They will be looking at the response. You have given a bolus and you have started the infusion, and you will keep on the CPR, and you will keep on everything resuscitative management. And if patient is not responding, then you may repeat a bolus, and you can increase the dose. And if it reaches 12 ml, but you see, it's very self-explanatory. In the exam, they don't want you to do PhD, but you have to be specific in your answers and safe, and you are not speaking like Imran Khan. You have to speak like someone very meticulous. Okay, because if you will be speaking recklessly, then you will be caught. Okay, so if you go back to, because different scenario in different question, they have different, if whatever they want to ask, they will go into it. Okay, like for example, if they want to ask about diabetes, even then you can use what sentence I have memorized you, Zishan, because other people, they have never attended, I think. If you can tell what I have told you, the sentence.
Sir, about the anatomical, physiological, and
Yes.
pharmacological changes?
For diabetes and hypertension, or any simple systemic disease. Especially for diabetes and hypertension, what is the sentence? There is macrovascular
changes
and macrovascular. Microvascular and macrovascular complications in the form of what are
there are
in the form
system wise.
You don't need to be so simple, Zishan. Just make your life simple. Microvascular, what are the common microvascular and macrovascular complications related to diabetes or hypertension?
Sir, eye changes, retinal changes, the renal changes,
Retinopathy,
retinopathy,
nephropathy,
neuropathies.
Nephropathy. Okay, neuropathy. Cerebral vascular disease, coronary artery disease, peripheral vascular disease. Okay, So you can make a sentence. Then I will be looking at the microvascular and macrovascular complication in the form of retinopathy, nephropathy, neuropathy, which and coronary artery disease, cerebrovascular disease, peripheral vascular disease. So I will be looking at any problem in eye vision, any this nephropathy will be visible in the form of
Proteinuria.
proteinuria and edema, and neuropathy in the form of autonomic dysfunction or sensory or motor neuropathy. Okay. And cerebral vascular disease in the form of stroke or TIA, and coronary artery disease in the form of ischemia, arrhythmia, heart failure. Okay. And peripheral vascular disease in the form of intermittent claudication and peripheral ischemic pain. Okay. So actually this is the common thing, and you should not forget. You just make a sentence in a way that you quickly tell what are the microvascular and macrovascular. This thing you should be in practice of doing in 30 seconds. Okay.
Right.
And if they want to ask any further question, they can ask you about control. The question the answer which usual 99% people say, I will take history, I will do examination. So what you will be getting? So you will be looking at the microvascular and macrovascular complication and causing and organ damage. Organ damage. Okay. And you will be looking at the control and how it is controlled, like what medications patient is taking and what are the side effects because of these medications and how is the compliance. Okay. About the medication, you need to know three things: how much is the control, any side effects, and how much patient is compliant. Okay. If they want to ask anything else, they will ask you. But usually in this answer, you will, and about the evaluation, you can say on the basis of history, examination, and relevant investigation. So you will be any end organ damage symptoms. So you will be thinking about any signs of heart failure. You will be looking at autonomic dysfunction. Okay. What else? You will be like heart failure signs is actually, you can elaborate if they want. Usually what is the end organ damage in diabetes or hypertension? Usually it is the main. Okay. And in diabetes, autonomic dysfunction. You can say about orthostatic hypotension and like fixed heart rate, and then investigation according to the history and examination. Okay. So you may need echo if there is any risk factor. Okay. You may need protein like this one CBC or coagulation profile, or according to the need X-ray, ECG, according if there is any indication. Okay. There is never use this word. This should be haram, baseline. What do you mean by baseline? People are in love with this word. And this is a crap word. In exam, it is a very terrible word. Examiner will be angry if you are telling baseline. You should be knowing what are the indications of echo. Why you want to do CBC? Why you want to do coagulation profile? Why you want to do X-ray? Why you want to do ECG? Okay. Why you want to do serum electrolytes? Like if there is a diabetic hypertensive patient, serum electrolytes, you can say that because of the medication patient is taking, and there are chances of, if the patient is taking insulin, there is chances of hypokalemia. If the patient is taking beta blockers, there is chances of patient having hyperkalemia. If the patient is taking diuretics, there are chances of hypokalemia. Okay. So things like that you can tell about the reason if they want to ask. But you will be saying that if you find any end organ damage and any symptom for which you need more evaluation, I will be doing echo. Like echo, we have discussed in detail. I will suggest you to listen in the YouTube about what I discuss in detail about echo. And because echo, they will ask you, and 99% people don't know what are the things to see in echo. Okay. So in this scenario, they will go like that. Can they do this carpal tunnel syndrome surgery in local?
Yes, sir.
They can do, okay, with anzulisis. Okay. Then if they may in their exam scenario question, they may be asking you about anzulisis. Okay. So if you are thinking about regional anesthesia, you should be, first of all, you should be knowing what are the nerves you need to block, what are the areas you need to block, what are the different options. For regional anesthesia, never forget about consent, explanation, resuscitation, proper gadgets to do it, like ultrasound or nerve stimulator, okay, or intralipid. You can specifically, in addition to resuscitation, normal resuscitation medication, intralipid is special for regional anesthesia. It is not there if you are not using regional anesthesia. There is no need for intralipid in resuscitative tray. Okay.
Yes.
And then safe calculation of the doses, and you may need to have some adjuncts. If you listen to the YouTube discussion we did for regional anesthesia, Zishan, just keep in mind.
Yes, sir.
Okay, that what are the factors for increasing the speed, what are the factors to increasing the duration, why you use lidocaine, this one,
Bicarb adrenaline.
why you add bicarbonate, okay, why you add opioids, why you add dexmedetomidine, okay. So you should be knowing about it. They can, and you can just speak about it. Okay? So the another question which they may ask about regional anesthesia is about epidural. Okay, so who will tell? Okay, so Faisal Sindhu, would you like to say something? Or you are silent listener?
सर मैंने तो अभी थोड़ी देर पहले ज्वाइन किया तो इसलिए मुझे कुछ चीजें.
You have viva or next time?
Sir, viva है.
Okay, so when will you be able to speak out? Viva is not, remember one thing, viva is not about reading, studying. Viva is totally different ball game. If you will speak out, you will correct yourself. Even if you read 15 hours a day and you are not practicing, it's useless. Just try to answer, okay? I will ask you a question and try to answer. You have a patient in labor, okay? You have to counsel about epidural, okay? So what things would you like to tell?
Labor. Sir, first I want to tell about the advantages and disadvantages of epidural.
Okay.
Or labor. First I want to tell her there is a just epidural will help her to bear the release her pain and
okay. You will be telling about procedure. Then what else? Procedure.
And
what are possible things you should be telling? What are the complications immediately can occur?
Immediately is
hypotension.
Hypotension.
Shell. Failure. Okay. What else?
The trauma.
EDPH. You may injure the, and then late complication infection and hematoma. Okay, I cannot recall the numbers. You should be knowing in 1 in 200,000 there are chances of sepsis. Okay. And 1 in 300 1 in 3,000 there is abscess, and 1 in 200,000 there is hematoma. Yeah, I don't remember it. Just reconfirm it. Okay. in how much
Yes, sir.
chances of PDPH, how much chances of partial and failure. So you should be knowing the numbers. Okay, you will find in this Google Drive link in regional anesthesia. In labor analgesia, you will find epidural counseling card. Okay, so I will suggest you to have a look at it.
Okay, sir.
Okay, so the majority of the things will be common. Okay, and how you calculate the dose of epidural or labor analgesia, what level you need?
Sir, at T10 to at the level of T10 to L1.
Okay, for first
first stage
stage.
of labor.
Very good. First stage T10 to L1. Okay. And second stage?
Second stage T11 to S2.
S2, S3, S4.
S4.
Okay. So this is mainly somatic and this is visceral. Okay. So how much and how much percentage you want to give bupivacaine?
1%.
1%. There is no
0.5
medication
to
of 1%. Okay.
No.
For
0.125% or 0.0625%.
Yes, actually for analgesia, it is 0.0625 to 0.25% maximum. Okay. Usually the common thing which we use is 0.1%. Okay. With 2 microgram per ml of fentanyl. Okay. For analgesia, usually we give not more than 0.25%, remember. Okay, for anesthesia, it is 0.5%. How much there in 0.25% per ml of 2.25%? How much bupivacaine is there or 0.5%?
2.5 milligram per ml and 0.25%. 5 milligram per ml.
2.5 milligram per ml. Okay, and 5 milligram per ml of what is the safe dose of bupivacaine?
2 milligram per kg.
2 milligram per kg. Okay. So for example, how will you calculate? You will maximum take 70 kg for female and 100 kg for males maximum. Okay. So for example, 140 milligram. This is, but for epidural, you don't need to give that much. This is usually for this one nerve blocks. Usually, okay. You cannot give this much in spinal, right?
Yes, sir.
And usually it is a blood level. So for bupivacaine, it is 5 microgram per ml. Toxic levels. You have to don't reach that one, because whenever you are giving medication by any source, it is being absorbed in the blood. Okay. Ultimately, that's why you add epinephrine to decrease the toxicity. Okay. To decrease, even with bupivacaine, if you want to add epinephrine, it is not to prolong the duration of action of bupivacaine, because bupivacaine is already long acting. Okay. So if you want to add epinephrine in this solution, it is to increase decrease the toxicity. Okay. And
actually in bupivacaine, the epinephrine just reduces its absorption rate.
Yeah, that's what I'm saying. That it is for reducing the toxicity. Okay. So this is for reducing the toxicity, and also for hemostasis. Okay. If they are giving in local infiltration, if they are giving epinephrine, this is for that reason. So these are the basic things, and they add this one dexmedetomidine. Okay. And they add also dexamethasone. Dexamethasone also increase the duration. Dexmedetomidine also increase the quality of block. Okay. Onset of block and duration of block. Dexmedetomidine, I'm not sure what, because I've never used it, so I cannot recall. Just have a look about it. And if you don't know, don't tell. if you tell only the things which you know, okay? Unless they are asking you what is the effect of dexmedetomidine. But because this is a common thing, you should be knowing what is the effect of adding bicarb. It increase the pH of the solution and make it towards pKa. Okay, so there is more increase unionized form. Okay, so it is increasing the onset. Okay, it is increasing the onset fast, make it fast. These are the basic concepts. Okay, Zishan, you know, yesterday after we finish, nobody asked any question. I'm stopping the recording.